are very often obese. The complaints are menorrhagia and or metrorrhagia. So more than heavy bleeding, they complain of intermittent bleeding and intermittent, sometimes watery discharge, foul-smelling discharge. How does the endometrium look? The endometrium appears heterogeneous. It is non-homogeneous. It is thick. The midline is not seen in any of them. Can you see? There is no midline seen. The margins of the solid area, if you observe carefully, are irregular. There may be some amount of intracavitary fluid, and it is this intracavitary fluid that helps us look at the irregular outline of the solid tissue. You may have myometrial invasion that can cause the endomyometrial junction to be indistinct, and I'll come to that in the next slide. There's increased vascularity of the endometrium. Can you see this? But this is very different from what we saw in hyperplasia. In hyperplasia, it was uniform, all of them crossing the endomyometrial junctions, running a parallel course. Here it is like there's a splash in the endometrium. Some vessels are long, some are short, or you may get multiple vessels in a focal area. Again, we'll come to the vascularity. So the vascularity is very, very random. Some areas are more vascular, some areas are less, some vessels are crossing the endomyometrial junction, some are not, some are round dots, some are long vessels. This is typical of endometrial malignancy. So let's look at endometrial cancer. Patient with focal endometrial cancer. I can hear somebody talking. I request you not to talk, please. So this was a 65-year-old patient who attained menopause 15 years back. She came in post-menopausal bleeding of 15 days. And what I saw, the endometrium was pretty thin, but there was some fluid. And I told you, fluid is our friend. What drew my attention is this very small little irregular area. You can see how tiny it is. But on zooming in, I realized there is really, in fact, something. It looks a little heterogeneous. It has spiky margins. There are multiple vessels crossing this focal area. And then here, this is that patient with irregular margins, multiple vessels. I did a 3D. On 3D, you can see the spiky edges. And this did turn out to be endometrial cancer. So this is a video clip. I just want to show you, if you're not paying attention, you can totally miss this lesion. Little bit of fluid in the endometrium. This little thing drew my attention. I zoomed into this area. You see, I'm zooming into this area. I'm seeing there are multiple vessels crossing this particular area. And now my focus is only on this polyp. I see the irregular margins, multiple vessels crossing, just very, very vascular polyp. Polyps are not that vascular, many vessels crossing. I do a quick 3D to confirm what I saw on 2D. 3D to confirm what I saw on 2D. And I see these spiky edges, and this did turn out to be a focal endometrial cancer. And the histopathology said less of the size was 0.5 centimeter. Now this is what we more commonly see in endometrial cancer, a very thick endometrium, again post-menopausal lady who came with spotting. See the irregular distribution of flow. Some areas are more vascular, some areas are less vascular. The vessels look very abnormal. Whenever there is thick solid tissue and increased vascularity, I always do a 3D with Doppler because I can get the whole vascular tree, and we'll come to it in a subsequent slide like you can see over here, then you can assess much better. I looked at the endomyometrial junction, it was not clear, so I did a 3D, I added BCI. Can you see? On the left side, I found that it was very thin. As I move to the right, I begin to see the endomyometrial junction well, and I see a thick myometrium. But as I move from the right back to the left, I cannot see it well, and you can see this irregular endomyometrial junction and very thinned out myometrium, telling me that there is myometrial invasion. Again, on Doppler, if you see over here, some vessels are crossing, some are oblique, some are dots. So it is just absolutely random increased flow inside the endometrium. So this is how you see the abnormal vascularity on glass body with 3D. You see there's a high density of vessels. They are randomly dispersed. Some areas have more flow, some areas have less flow. There's multiple branching and frequent branching of vessels. There are tortuous and coiled vessels in contrast to the straight vessels or the gently curved vessels we saw in hyperplasia. The vessels will vary in caliber. Some are thick, some are thin. In addition, in a single vessel, you may see areas with microaneurysms which look dilated and stenotic segments like you can see here and you can see here, and there's looping and bridging of vessels. So moment you see this, you know that this is malignancy. How do we assess myometrial invasion? How I do it is, you can see in this particular patient on the right side, With 2D, I could see right side the endomyometrial junction was seen, but on left side I couldn't make out the endomyometrial junction. When you cannot make out, you should suspect myometrial invasion. So I did 3D with VCI. You see the endometrium over here. The myometrium overlying the endometrium is 5 millimeters thick, and I could see this on 2D. But what about the left side? The left side with 2D, I couldn't see anything. With 3D, I saw that there was a very thin myometrium, and I could make out this irregular endometrial outline telling me that there is myometrial invasion. So the same area on the right side was 5 millimeters thick myometrium, and on this side it was only 1.3 millimeters, telling me that there is more than 50% myometrial invasion. And that is what the histopathology showed, more than 50% myometrial invasion. Now, if you just look at the vascular morphology of patients on 2D and 3D, in patients with a thickened endometrium. So very often you have a thick endometrium, whether the patient is symptomatic or she's referred to you for a thick endometrium. If you see a single vessel entering that thickened endometrium, think in terms of a polyp. If you have multiple vessels all crossing the endomyometrial junction and entering the endometrium, think of hyperplasia, but you can also see this with secretory endometrium. Remember, this is normal pattern of flow, and you may see the same pattern with secretory endometrium. Of course, here we are talking about a patient who's come with excessive bleeding, who has a thick endometrium and the flow is excessive. In carcinoma, you can see that there is a random dispersion. Some of them are long, some of them are short, round, cut sections of the vessels, and some only are crossing the endomyometrial junction. On 3D, this becomes even more clear. You see the pair of vessels entering and branching within. This is 3D with Doppler. Here you see the pattern is very similar on 3D and on 2D, but here you see that the pattern is extremely abnormal. This is the same patient on 3D. So 3D Doppler in a thick endometrium quickly will tell you the difference between hyperplasia and malignancy. Now this is the last case. 66-year-old patient came with, who was menopausal for 16 years. She came with pain abdomen. They did a CT. CT showed an omental nodule and a thick endometrium. So they sent her to evaluate if there was any pelvic cause for the omental nodule. The endometrium was 90 millimeters thick, which is very thick. Again, arcuate vessel calcification because she's an elderly lady. And this is a video clip. Can any of you tell me, is this a polyp? Is this hyperplasia or is this malignancy? You know why I turned to sepia? Because eye perceives color better. So sometimes in challenging cases, it's a good idea to turn your sepia on. Maybe you can see something more. I'm seeing, I thought one cystic space. I said, oh, maybe there is an endometrial midline. I wasn't sure because endometrial midline is not seen in patient. It's in hyperplasia, you may see it, but you won't see it in malignancy. I'm trying hard to find a vessel. Remember, I'm seeing vessels, but I'm not able to see a vessel, feeder vessel crossing the endomyometric junction. So I was at a total loss. What is it? Could be carcinoma, unlikely to be hyperplasia. But guess what? Because I couldn't see a single vessel, neither could I see that it was not excessive, it was not, I was totally at a loss. So we did sonohistogram, and this patient was not symptomatic. With such a thick endometrium, if it's endometrial cancer, you think in terms of some symptoms she'll have of intermenstrual bleeding. She had nothing. So what we did was we did a quick sonoserine infusion, and here you see I put my catheter in, and now tell me what it is. I do a quick 3D. What do you think it is? Polyp. And a benign polyp because it has smooth margins. So this is where, you know, sometimes saline infusion sonography can be extremely helpful, and she did undergo hysteroscopy and the report said benign endometrial polyp. So to conclude, I basically discussed only common pathologies which are unrelated to pregnancy, polyps, hyperplasia and cancer. Remember, symptoms and ultrasound findings of these three may overlap. The best time to evaluate the endometrium is in proliferative phase in women of the reproductive age group for two reasons. One is any pathology stands out better. Secondly, secretory endometrium may appear like hyperplasia, may appear polypoidal and will cause a lot of confusion. So if you see something in the secretory phase, it is good to call her back in the proliferative phase to confirm your findings.